This episode is adapted from a clinician-written article on Mentalyc and brought to life in audio for therapists who prefer listening on the go.
That's right. This piece was written by Dr. Salwa Zainuddin, and we're excited to feature their perspective here.
Absolutely. And just for a little context, if you're new to Mentalyc, it's a clinical intelligence platform that supports therapists with documentation. It's designed to make our lives a little easier, which we can all appreciate.
Oh, can we ever? It makes me think of that very specific feeling. You're sitting with a client, and the session is fine, it's productive, but there's this undercurrent, something you can't quite put your finger on. Their words are saying one thing, but their whole presence in the room is communicating something else entirely.
Yes, that dissonance. It's that moment where your clinical intuition is buzzing, but you don't have the language for it yet. You're trying to hold the therapeutic space, listen deeply, and be an expert observer all at the same time. It's a lot.
It is, and that's exactly what we're diving into today, giving that intuition a framework. We're talking about the mental status examination, the MSE. And I know, for some, that term can sound so clinical, cold, maybe even a little sterile.
Right? Like you're just going down a checklist. But I've really come to see it differently. It's less of a checklist and more of a systematic way of being curious. It's like a psychiatrist's version of a physical exam, but for our world, for mental and emotional functioning.
I love that framing, a physical exam for mental health. It's about creating this holistic picture of a person in a specific moment in time. It's not about diagnosing in that second, it's about observing. And it all starts with the most immediate thing, what we see.
Exactly. Appearance. And this is an area where we have to be so careful not to make assumptions. We're taught to note things like grooming, clothing, hygiene. Is their clothing appropriate for the season? Do they appear neat or disheveled?
Right. And those observations are data points, but they aren't conclusions. I remember early in my career, I had a client who always came in looking absolutely impeccable. Perfectly dressed, hair done, makeup flawless. On paper, you'd write, well-groomed, neat appearance. But she was struggling profoundly with depression, to the point where getting ready for our session was the only thing she could accomplish all week. It was her armor.
Wow. What a powerful example. And it's why we have to go beyond the surface. It's not just client appears well-groomed. It's about gently inquiring. Asking, I notice you always present yourself so thoughtfully. I'm curious what that's like for you. Is that process energizing, or does it take a lot out of you?
Yes, that's the respectful curiosity. The same goes for someone who appears disheveled. The assumption might be depression or lack of self-care, which is often true. But it could also be exhaustion from a new baby, or living with chronic pain, or maybe they just biked to the session in the rain. We have to ask, how has attending to personal care been for you lately?
And even posture and gait. Is someone's posture open and relaxed, or is it closed off, slouched? I had a client who always sat perched on the very edge of the couch, like he was ready to bolt. And his gait was always so hesitant. It spoke volumes about his anxiety and lack of safety in the world, before he even said a word.
It's a form of nonverbal communication, isn't it? And that leads right into the next piece of the MSE puzzle, behavior and psychomotor activity. This is where we're looking at attitude, eye contact, facial expressions, gestures, all those subtle cues.
The micro expressions. You see a flash of anger or a flicker of sadness that disappears before they even seem to notice it. Or their eye contact. Is it piercing and intense or avoidant and fleeting? Does it feel guarded or open and engaged?
And the psychomotor piece is huge. Are they agitated, restless, tapping their foot, pacing? That can signal anxiety, mania, or even akathisia from medication. Or is it the opposite? Psychomotor slowing, where every movement seems heavy, effortful, that classic sign of severe depression.
That slowing is so telling. It's like you can physically see the weight of the depression on them. And then you have other things like tics, tremors, or other abnormal movements. It's so important to note those because they could be related to a psychiatric condition, or they could be extrapyramidal side effects of antipsychotics. We have to be detectives.
We really do. And let's be honest, trying to track all of this, appearance, posture, gait, eye contact, gestures, mannerisms, motor activity, while also being present and empathetic, it feels impossible sometimes. You're trying to remember all these descriptors: disheveled, guarded, agitated, lip smacking, psychomotor slowing. My brain can only hold so much in the moment.
Exactly. You're trying not to sound like you're reading from a textbook in your head. That's actually where I found tools like Mentalyc to be so helpful. In their template builder, you can customize your progress note to include the specific MSE domains you want to focus on. So the structure is already there. You don't have to reinvent the wheel for every single note. It just prompts you: behavior, psychomotor activity. It helps organize your thoughts after the session.
Ah, that's a game changer. So you're not starting from a blank page, trying to recall every little detail. You have your preferred scaffolding ready to go. That frees up so much mental energy because the next part, speech, is a whole universe in itself.
A whole universe. It's not just what they say, it's how they say it. We're looking at rate. Is it rapid and pressured, like you can't get a word in edgewise, that classic sign of mania? Or is it slow, hesitant, with long pauses, which might suggest depression or even psychosis?
And the volume and tone. Is their voice loud, booming, or is it a soft whisper? Is it monotonous and flat, lacking any prosody? That normal lilt and rhythm of speech? A flat, dull tone can be such a strong indicator of depression or a negative symptom of schizophrenia.
That brings up the form of speech, too. Is it logical, or is it all over the place? Like circumstantial speech, where they give you every single irrelevant detail before finally getting to the point. I went to the store, but first I had to find my keys, and my dog was barking, and the neighbor's car was blue, you know? It can suggest anxiety or obsessive traits. Yes, or tangential speech, which is even more disconnected. You ask them about their week, and they start talking about their week, but then that reminds them of a movie, and the movie reminds them of a vacation they took 10 years ago, and they never, ever come back to the original question. They just veer off into the sunset.
Right, which is different from flight of ideas in mania, where the connections are even looser and faster, often based on rhymes or puns, clang associations. It's like watching a pinball machine. And then there's the most extreme end, word salad, where the speech is just completely incoherent, a jumble of words with no logical connection at all.
It's so complex. All of these observations, appearance, behavior, speech, are the external manifestations of what's happening inside. Which brings us to the core of the MSE, mood and affect.
The big two, and it's so critical to understand the difference. Mood is the client's subjective, self-reported emotional state. It's what they tell you. It's the answer to, how have you been feeling lately? We ask, and we quote them. Client reports mood as depressed and hopeless.
Exactly. Mood is the climate. We ask them to describe it in their own words. Is it euthymic, which is that normal stable range, or is it dysthymic, irritable, anxious, euphoric, angry? We're documenting their internal weather report.
Affect, on the other hand, is the weather. It's their moment-to-moment emotional expression that we observe. It's in their facial expression, their body language, their tone of voice. This part is purely observational. We don't ask questions here, we just watch.
And we describe it using a few key dimensions. There's the quality. Is the affect sad, agitated, hostile? There's the intensity. Is it blunted, meaning reduced emotional expression, or flat, meaning a near total absence of it? And then there's the range. Is it restricted to just one or two emotions, or is it a full, healthy range?
And my favorite one, congruence. Is the affect congruent with their mood and the content of their speech? A client might be telling you about a deeply traumatic event with a smile on their face and a light, cheerful tone. That's incongruent affect, and it's a major red flag. It tells you there's a disconnect somewhere that needs to be explored.
Absolutely. Or a labile affect, where their emotions shift on a dime, laughing one second, crying the next, then angry. You see that a lot in mania or certain personality disorders. All of this is just so much to keep in your head. It's why having a structured way to document it is not just helpful, it's essential for good clinical care.
Quick pause. If this part of the work feels familiar, that feeling of trying to capture all these moving pieces, Mentalyc can help. Its AI note taker supports your documentation and clinical judgment by structuring these observations for you. And it stays fully HIPAA and SOC2 compliant. You can explore it at Mentalyc.com.
That's a perfect place for a pause because we're about to go even deeper into the thought process and thought content. This is where we move from observation to direct inquiry about what's on the client's mind.
Right. Thought content is the what. What are they thinking about? We ask directly, what's been on your mind lately? Do you have any worries or concerns? This is where we assess for things like obsessions, those intrusive, unwanted thoughts they can't get out of their head, and critically, where we assess for suicidal or homicidal ideation.
Yes, the risk assessment. Asking clearly and without judgment, have you had any thoughts that life isn't worth living? Have you had any thoughts of harming yourself or anyone else? It's our ethical duty to ask these questions.
And we also look for delusions, those fixed, false beliefs that are held despite all evidence to the contrary. Grandiose delusions, I'm a secret advisor to the president. Persecutory delusions, the FBI is tracking me through my dental fillings. Or ideas of reference, where they believe random events have a special meaning just for them.
That's different from thought process, which we touched on with speech. Thought process is the how. How are their thoughts organized? Are they logical and goal-directed, or are they tangential, circumstantial, or showing a flight of ideas? You can have logical thought process with delusional content, or disorganized process with normal content. They're separate domains.
It's such a crucial distinction. And this is also where we might note thought blocking, where a client is talking and then just stops, mid-sentence, as if the thought vanished, or thought insertion or withdrawal, which are psychotic symptoms where they feel thoughts are being put into or taken out of their head.
These are obviously more severe symptoms, but they are vital to capture accurately. And again, having a system matters. When you're using a tool like Mentalyc, it can capture the details from your session and help you organize them into these specific MSE categories. So after a difficult session where a client disclosed delusions, you're not scrambling to remember the exact phrasing. It helps you create a clear, accurate record, which is so important for tracking these symptoms over time.
That longitudinal perspective is everything. Is the thought content becoming more or less delusional? Is the thought process getting more organized? Seeing that laid out session after session in your notes is how you measure progress and make informed clinical decisions. And this leads us to perception.
Right, the sensory experience. Are they perceiving reality accurately? This is where we screen for hallucinations, sensory perceptions without any external stimuli. Auditory hallucinations are the most common in psychosis, like hearing voices, but they can be visual, tactile, feeling bugs crawling on the skin, olfactory, smelling things that aren't there, or gustatory, tasting things that aren't there.
And it's important to differentiate hallucinations from illusions, which are misinterpretations of real stimuli. For example, seeing a face in the shadows or mistaking the rustling of leaves for someone whispering your name. Illusions are more common and less pathological, but still important to note.
And we again ask directly, but gently. Have you ever experienced things that other people don't seem to see or hear? Do things sometimes seem unreal or distorted to you? This is also where we can ask about depersonalization, feeling detached from oneself, like you're watching your life in a movie, or derealization, feeling like the world around you isn't real.
These experiences can be terrifying for clients. Creating a safe space to even talk about them is half the battle, and documenting them accurately is the other half. Okay, so we've covered a ton. Now we get to the higher level stuff. Cognition, insight, and judgment.
Right. Cognition is a big bucket. At its most basic, we're assessing orientation. Oriented times 3 or times 4. To person, place, time, and sometimes situation. What's your full name? Where are we right now? What's today's date? It seems simple, but if a client is disoriented, that's a major sign of something serious, like dementia, delirium, or a brain injury.
And this is where some clinicians might use a formal screening tool like the Mini Mental State Examination, the MMSE. It's important to remember the MSE is the broad clinical assessment, and the MMSE is a specific scored cognitive screener that can be part of the MSE, but isn't the whole thing.
That's such an important distinction. The MSE is a qualitative, descriptive process. The MMSE is quantitative. Beyond orientation, we're also informally assessing attention, concentration, and memory throughout the session. Can they stay on topic? Can they recall information you discussed earlier in the session?
Which all builds up to the final two and arguably most important domains for treatment planning: insight and judgment. Insight is the client's awareness and understanding of their own condition. Do they believe they have a mental health problem? Do they understand how it affects their life? Do they see a need for treatment?
This is huge. A client with good insight might say, I know my depression makes me isolate, and that's why I need to come to therapy. A client with poor insight might say, I'm not depressed. My family is just dramatic. There's nothing wrong with me. Their level of insight dramatically impacts how you approach treatment.
You can't work on a problem the client doesn't believe exists. And judgment is closely related. It's their ability to make sound, responsible decisions and solve problems. You assess this by exploring their recent decisions. Are they making choices that keep them safe and move them toward their goals? Or are they engaging in impulsive, self-destructive behaviors?
Exactly. A client with poor judgment might be spending their rent money on lottery tickets or getting into fights. Their ability to anticipate the consequences of their actions is impaired. And we usually describe both insight and judgment as good, fair, or poor.
And that really brings it all full circle. From their appearance when they walk in the door to their ability to make safe choices when they leave. The MSE gives us a comprehensive, structured way to understand and document the whole person. It's not a cold, sterile checklist. It's a roadmap.
It really is. It transforms that vague, intuitive feeling of something is off into specific, observable data points that can guide our work. It helps us track progress, communicate effectively with other providers, and ultimately provide better care.
So, if we were to leave our fellow clinicians with one practical takeaway from all this, what would it be? Because trying to master all 10 domains at once is overwhelming.
Understatement of the year. I think the takeaway is to start small. This week, pick just 1 or 2 components of the MSE to focus on. Maybe you decide to pay extra close attention to your client's affect. Notice the range, the intensity, the congruence, or maybe you focus on the rate and rhythm of their speech. Just sharpen one tool in your observational toolkit at a time.
That's so much more manageable. Don't try to be an expert on all 10 things by Friday. Just be a little more intentional in one area. Over time, that intentionality builds, and the whole process becomes second nature. It becomes less of a thing you have to do and more of just how you listen.
Exactly. It becomes integrated. And as you get better at observing these details, having a reliable way to document them becomes even more important. You don't want to lose all that rich data.
Absolutely. And if you want support making MSE documentation a consistent, stress-free part of your workflow, Mentalyc's AI note taker and customizable templates can really help with that. It helps you capture the richness without the administrative headache.
Couldn't have said it better myself. It's about letting the tools support the work so we can stay focused on the human being right in front of us.